how to avoid complications of lumbar fusion. Yahya, it's your turn.
Okay. Dear colleagues, hi everyone. I am trying to tell you how to avoid lumbar fusion complications. Lumbar fusion complications are not a common. We see sometimes, and sometimes correct them is very difficult. So it is very important. Most important thing is prevent complications. A lot of complications are minor complications. These complications sometimes present with pain. Sometimes they come to the neurological symptoms, sometimes progressive deformity. And most important thing is, I think some patient has high risk. For example, rheumatoid arthritis, Parkinson's disease, ankylosing spondylitis, and tobacco use, and revision surgery, and adult degenerative scoliosis. During operation, increase blood loss and prolonged surgical time has high-risk complication. And there are major complications. This is neural injury, transitory neurological deficit, symptomatic non-union, and pulmonary emboli, deep venous thrombosis, iliac vein injury. Minor complications are dural tear, radicular pain, wound infection, ileus, postoperative anemia, urinary infection, adjacent segment disease, instrument breakage, and hematoma. And we will talk some frequently seen complication, for example, pseudoarthrosis. There is some criteria in radiographic assessment on osseous fusions, and there are some symptoms. And prevent pseudoarthrosis is aggressive removal of fibrous tissue and extensive decortications, use of autologous bone. This is prevent techniques. For example, this patient has simple case, but there is no any fusion in here. This is pseudoarthrosis after 3 months later, and there is very easy because this is titanium cage. Sometimes we use interbody cage, but this is fully metals, but we need to use inside autolog graft. If we use only this cage without any autolog graft, sometimes we can't achieve fusions. This is very simple, very easy, but we need careful using for these devices. The other prevent pseudoarthrosis, replacement of implants when encouraged is questionable, conversion to circumferential fusions, extension of fusions and correction of alignment, and restore sagittal balance. For example, these patients have L2 burst fracture, and it's operated like that, but she has a kyphosis in here. This is unbalanced spine. After operations, 1 month later, she got infections. Again, she operated second operations, and again put some secrets T level superior and T levels inferior. Again, no interbody graft or supporting anteriors, and there is no any correction sagittal balance. Again, seeing pseudoarthrosis in here. So we accept the patients. Now this is very new patients. We remove all of the secrets. Before operations, she has very severe pain related with pseudoarthrosis, and she can't walk. After remove all of the secrets, she can walk, and she has minimal pain. But she has again sagittal imbalance, and we will correct this sagittal imbalance, and we will take second operations. And another complication is instrument breakage. For example, we can prevent with correct planning, and we can decrease stress on instrument for anterior support and for correct selections of level of operations, spines levels, and sometimes we need osteotomy for prevent instrument breakage. For example, this patient is 16 years old. She has birth fracture in here, and she operated like that. If we make correct planning, we can prevent complications. This is very weak for these patients. Only one level below the major area. It is not necessary for corrections and for heavy the spine, and we need extra level the inferior. And after 1 year later, she has instrument breakage, and we can restore again. And the other complication is prevent adjacent segment diseases, and the correct selection of fusion level. This is prevent techniques. The correct selection of fusion level is very important. Don't stop unbalanced segment, and improving again sagittal or coronal plane imbalance. For example, this patient is have adjacent segment disease in here. There is a fusions. We accepted these patients. We remove all of the screws, and we add new screws. We made decompression in here. But important thing is in here, there is a degenerative segments and minimal listhesis. So we add the instrument in here like that for, and we use hybrid route for prevent new adjacent segment designs in the features. And another complication is proximal junction kyphosis and proximal junction failures. Symptom is pain, walking disturbance, and neurological deficits. This complication has some risk factors. If we prevent these risk factors, we prevent this disease. For example, extensive paraspinal muscle dissections at the upper instrumental vertebra lead to these complications. We avoid from this. Disruption posterior tension band, I think this is very important. Improper and vertebra selections and proximal severe disc degenerations is important when you stop some upper levels. We will continue sometimes. And compression fracture at the most instrumental vertebra and instrumentation failure at the proximal construct and facet violations. These are caused PGK and PGF, and if we prevent this, we prevent these complications. And autograph for spinal fusion is very, very important because this increase fusions and prevent complications, prevent pseudoarthrosis, prevent pull-out, and we should select autograft instead of synthetic grafts is very important. For example, this is a case which we used autograft. He is 20 years old and he has chondrosarcoma in here in sacrums, and this chondrosarcoma start from here and go to lateral side of sacrums and invite to C1, C2, and we operated it with together with orthopedic surgeons. We remove a single part. This is C1, this is C2. We remove half of the sacrums, but we need strong fusions And there is a very big, huge area in here, and we use autograph. We take from iliacs. It is 10 centimeter iliac graft, and we take it and we put here horizontally. After that, this is the postoperative CT and X-ray. Sometimes we use transverse, but we take only hemi-sacrectomy, and we put in here transverse, and we put between graft and normally sacrum a screen. We get actually very, very strong fusion in here. This is postoperative 1 year, and he can walk. There is no any complication. This is a graft area, iliacs. And the other complications is pull out, screws pull outs. There is some techniques for screw replacements. Some of them is putting parallel to end vertebra. Some of them is using anatomical plasmas parallel to pedicles. In osteoporosis patients and in older patients, we select these techniques because this is very strong area below the end plates. It is important for this is trajections, and another thing is trajection is we know change in upper thoracic level and middle thoracic level and upper thoracic levels. And when you use pedicle screws in cervical area, again, trajection is very, very important. And we should use correct trajections for prevent screws pull outs. Another complication is infections. This is our department's patients. We operated her for long level instrumentations. After 3 weeks later, she has pneumonia, she has rheumatoid arthritis, immunosuppressives. She first gets viral infections after it's turned pneumonia. After 1 week's pneumonia, the infection spread with hematogen, maybe in operation area there is infections, and so she come back again like big abscesses in here. We take her immediately operations. So how we can prevent infections using prophylactic antibiotics and pre and per-operative. If operations time is long, we add again new antibiotic during operations, and sometimes we use some antibiotics put on the screws sometimes. And how we prevent infections with getting shorter operative time, debridement of any necrotic appearing muscles. We make it every operations at the end of the operations, and irrigations of the procedures. Sometimes we use 1 liter serum physiologics for washings everywhere if you make long level instrumentations. Another thing is release retractors during operation is very important. And postoperative care is very important because postoperative care is given with patient's family, and we tell them how they look at the patients on first and second week after discharge is very important again. And neurological complications, sometimes this is catastrophic. Because of that, it is very important. There is a rare but important. Sometimes it is occur with direct injury, some surgical instruments. For prevent it, we use 2 hands. We use 2 hands for this surgical instruments, and we work carefully, and we work step by step as a team. The nurse help to us, and the assistants help to us. We don't make all of the things with two hands, and sometimes we must careful, and sometimes misplacement of screws and hooks cause neurological deficit. So we use fluoroscopy before operation and at the end of the operation. If as some unconfused for placement of screw, we again need check with fluoroscopy during operations. And another thing, compression to neural tissue make again a complications. For example, with cottons, with fat grass, with duraceilings products, with hematoma and pseudomeningocele after operations, and epidural abscess and recurrent disc herniation, again, late complications, late neurological complications. And how to avoid lumbar fusion complication in deformity surgery, because we have some high risk in deformity surgery. We use these fusion techniques, but in deformity surgery, it's high, related with instrumentations and sometimes related with techniques. Because of that, there are some prevalent techniques. For example, if we make good correction deformity and we achieve good lumbar lordosis and we achieve sagittal balance, we get at the same time strong fusions, and we see in the patient's back pain reduce. This is very important, corrections, deformity, and getting lumbar lordosis. And we need to make sagittal balance corrections. How we can do that? For anterior releasings, for anterior colon sports and vertebral osteotomies, help to us getting sagittal balance. And this is some adult degenerative scoliosis. For example, in these patients, we need to make osteotomies in here for reduce stress on instruments, for prevent breakage of instruments, for prevent pull-out instruments. In this area, it is very important to apply osteotomies. And another things, we put interbody graft for getting fusion in lumbosacral area. It is important. Again, in these patients, again, adult degenerative scoliosis, we made osteotomies in here because there is a very rigid area in here. If we make osteotomies correct levels, if we select upper levels for fusions and correct inferior levels, again, we reduce stress of this instrumentation. So we prevent pseudoarthrosis, we prevent again this instrument breakage. And another issue is how to avoid lumbar fusion complication in osteoporosis surgery. For example, this is we avoid for using instrumentation in osteoporosis patients. If we came to us osteoporotic patients, we try to use minimal invasive techniques, for example, kyphoplasty or vertebroplasty. But sometimes this patient came to us with neurological deficit, so we must use these instrumentations. We use very rare in osteoporotic patients instrumentations because of that it has very high complications. And when we use these instrumentations, we careful and we have some strategy. For example, in kyphotic segments, we use 3 levels above and 3 levels below the fractures levels, and don't stop instrumentations in junctional area, and kyphos is the apex. And if S1 shouldn't be included, L5 S1 is intact, And so if we must go to the S1, we put interbody graft between L5 and S1, and sometimes we add iliac secretes and sometimes S2 secretes, because we know if we go to the iliac and S2, the fusion rate is 3 times more than the other parts in osteoporosis patients. And this patient has a neurological deficit and osteoporosis patients, and there is a fracture in here. We use long levels instrument, and we put vertebral augmentation in here, and we put here short secretes. Again, osteoporosis patient, but this is different form of patients, because T-score is very high. This means getting fusion is very difficult. These patients, so in these patients, we are trying to prevent posterior spinal complex, spinosporosis and interligaments. We are try to keep posterior elements, and so we make only hemilaminectomy in here. We don't make total laminectomy, because we are trying to keep the posterior elements, and we select fenestrating secretes in here, and we put in here anterior augmentation. All of these techniques for getting fusions, but sometimes we can't achieve fusions. So we think 2 times when we use these fusion techniques in osteoporosis patients. I want to show 2 cases about complications. This patient come to us unbalanced spine, walking disturbance, and we see in here a rod. These rods put here strategically. There is no enough lordosis in here. After 5 years later, he has flat back syndromes and high cervical vertical axis, and like this is kyphotic posture. And we make some osteotomies, and after that we make restoration lumbar lordosis, and this patient turn like that. Again, a patient, she has 3 operation history, 3 operation in these levels, and again, there is not enough lordosis in rods, and there is no interbody grafts in here. So there is no achieving good lumbar lordosis. After 3 years later, she has again severe back pain and walking disturbance. We make revision surgery, we make lordosis again, and we go upper levels for prevent complications. Another and last case is this patient has again instrumentations, but there is some wrong things, because this is not rod, this is plate rods, and these devices can't make enough lordosis in here. The second thing is the level is in the thoracolumbar junctions, and so in this patient we see pull out in here T12 and blows, and there is a high cervical vertical axis, 32 centimeters, and There is a kyphotic postures and he can't walk. This is normal positions. We take operations, we make some osteotomies in here, but there is a fusion at the inferior level, and there is some interbody graft from old operations, but there is a fusion, scoliotic fusion in here, in L4, L5, and S1. So we stop in here, we pull out all of the screw and we put in here again new screw, but there is a very big hole in here. We put in a hole autograft and there is again big hole in here, old screw area. We fill all of the hole with bone graft and we put new screw in here, but after 5 months later, we see again pull out in here, pseudoarthrosis in here. This is our fault because we think it is enough for patients, but the kyphosis is very high for these patients, and there is a very big stress in lower segment, and it isn't enough for using old screw area for these patients. There is a like that post-operators, but after 5 months later, there is a pull-out here. Then again, we take second operations and we must go below and we use 2 screws to iliacs, to S1, 2 screws, because L4 and L5, there was a very weak, and we put some roots, double roots in here. So after these operations, we're getting good corrections. There is no pain after operations, but again, he has some coronal imbalance, minimal coronal imbalance, but he can walk easily now. And as a conclusions, patient selection is very important because Professor Zileli and Professor Richards say for minimal invasive surgery and fusions, it is very, very important. And I think one step is patient selections. If we select wrong patients, we can see complications, fusion complications easily. And the other things is the comorbid factors. For example, rheumatoid arthritis, Parkinson's disease, and osteoporosis. It is very dangerous for using techniques, fusion techniques. If we have necessary, really necessary, we can use fusion. But if we haven't any obligations to fusion, we can use minimal invasive techniques for these groups. And radiological factors important for making plane, for getting good balance. If we get good balance, this means we have less stress to instrument and we can easily to fusion, because we need to look at the radiological factors. And surgical planning, again, important. Which level we go upper level and which level go inferior levels. And sometimes we need to use osteotomies. Thank you for your attention and listening to me.
Yeah, thank you so much. It was really a good presentation. So, dear friends, if you have any questions, please write on the chat part. So, Sultan El Kalbani is asking, I'm asking to Zileli and also Yahya Mensret, do we have any objective score for instability in degenerative spine?
Yeah, actually, I didn't show those slides. Dr. Arvind Kulkarni has promoted a scoring system to decide if the instability is quite prominent. If it is, then those patients will go to surgery. If not, to more conservative therapies, because there is no very strict criteria that those patients must go to fusion and those must not go to fusion. There are some, yes.
So Serdar Ercan is from Turkey is asking, Yahya, do you have any advice to prevent bone loosening around screw, especially at sacrum? You have told us some techniques, but do you want to add something?
Yes, because S1 pseudoarthrosis we see easily to S1, so we are trying to placement S1 to promontorium. If you don't go to the promontorium, it is easily go out again. We can see pull-outs. Trajection is very important. The second thing, we need to placement interbody graft between L5 and S1, because this have to getting less stress to posterior secretes. So we put in interbody graft. This interbody graft have to heavy load to anterior shared loads, and again have to prevent pull-outs. And we use again autograft around to secretes.
And Yahya, we have seen very good cases from you. So do you advise less invasive, let's say, ponteosteotomies for the adult degenerative cases, or do you prefer pedicle substruction osteotomies? How do you decide the type of the osteotomy or the level of the osteotomy during your surgeries?
I select pontostotomies because it is easy and less blood losings, and it is hard to us. But in pedicle subtraction osteotomy, yes, we get things extra angles and extra corrections, but it has leads to great blood loss. If we have, for example, in flat back syndromes, there is a lumbar kyphosis, it is easily correct with pontostotomies, but sometimes this case is only 20 degree kyphosis, not lordose kyphosis, it is enough. But if some patients have 40 or 50 degree in lumbar kyphosis, but we can't see in adult patients, it is very rare. In congenital deformities, sometimes we can see these patients. We can select pedicle subtractions osteotomy. It helps to us. The other options, if this kyphosis only making operation, it is enough for using L1 and S1 instrumentations. We don't need to go upper level for corrections. We can if we correct with short segment, we can select pedicle subtraction for L3. It is optionals. If we have very high SVA, I go to the upper level with osteotomies. But if we don't have very high SVA and only high degree in lumbar area, I can select pedicle subtraction osteotomy. But frequently, I select pontostotomies.
Thank you, Yahya. Yes, really.
We have some very nice faculty with us, especially Marcos Massini, Oscar Luis Alves, Eko Subakyo, and Ruli Hanefi Dalan. We can ask their comments on the subject.
Yes, Oscar Massini, Eko. Would you like to add? Would you like to comment on the topic?
Start with Marcos. Marcos is here.
Marcos Massini.
Marcos has left us, I think. We can ask Oscar then.
Yeah, Oscar is here. Eko is here. Oscar?
I have no comment, Doctor. I think.
Hi, Eko. How are you?
Fine, thank you.
Please,
Thank you, Professor.
please tell us about the indications and techniques of lumbar fusion. What is your comment?
Yeah, my comment is there are several indications for lumbar fusion. Lumbar fusion is if the lumbar become unstable. This is number one. Or two, because our operative technique make that lumbar disc become unstable. And number three, if we want to improve to become make lordosis become normal lordosis, I mean.
Thank
This
you.
is my
Mehmet, sorry.
Hi.
Onur, sorry. I guess. And I
Yeah.
just could say something. I think the Zileli lecture was really outstanding on pointing out the need for fusion. And, you know, there are things that you can read in the literature that are things that come from your experience. And the thing is, my experience is when I'm getting older, I try to do less and less fusions. And this would be my message for the young people in the audience. Fusion itself, as has been shown, has a lot of problems and complications. So whenever you can save them, whenever they are not really needed, we should think more on decompression. Perform what I call symptom-based surgery, which is not easy because we were taught to look at the scans and operate on scans, on MRIs, and we think we should come back again and look at the symptoms of the patients. It's probably much more difficult to spot where the problem comes from and do more symptom-based surgery. And of course, all these minimal invasive techniques, tubular, and especially endoscopic techniques can allow us to do more symptom-based surgery, which sometimes, you know, a lot of times the patients are quite happy with that. So once again, congratulations for this webinar. It was really great one.
Yeah. Thank you. I think we already skipped that point that we are not causing iatrogenic instability nowadays with the current techniques. Can we say that? Probably. Although there is no good high quality papers, but MIS techniques.
Yes, I agree, Mehmet. Yes, with all the knowledge that we have with the pelvic indexes and MIS, this certainly can help us a lot to reduce adjacent segment and creating instability with surgeries. And this was a great advancement, in my opinion.
So also for the deformity surgeries, I'm not sure who has told us, but they say that every spine surgeon is a deformity surgeon. Someone creates the deformity and the other tries to correct it. So I think from this webinar today, we have learned lots of things, but in the future, I think especially the deformity surgeries will be done with minimal invasive techniques, and try to reduce the fusion levels will also reduce our complications in the future. I'm talking about lumbar adult degenerative scoliosis cases. They have very high complication rates. We can say 40% of them may have complications in the future. So we have to talk very good before the surgery to talk about the complications of these surgeries. And if we can do it, we have to do it with minimal invasive techniques. These are the things that I may say about this webinar today. I think everything is fine. And last first, Zileli, would you like to say something, Yahya, so that we can close the webinar?
Yeah. Actually, we must be very careful to avoid complications. So then in all our talks, we must have a section for complications. Otherwise, if you do not know the complications, the reasons of complications, you cannot avoid them. So then you'll be announced as a failing or fail creating surgeon. This is not good. Everybody must be aware of that. Thank you, Yahya, for mentioning us many complications of fusion. There is one question, I think, from the audience that asking what is the role of cage in traumatic unstable lumbar fracture fixation? What is the role of cage in traumatic unstable lumbar fracture fixation? I can simply answer this. If there is a burst fracture, and if you have to restore the ventral column, it's better to place a cage together with good autographs. That may be answered this way, I think. Otherwise, not all lumbar fracture dislocations need a anterior cage. Only those who have significant burst fractures.
Zileli, Yahya, thank you so much. So we will announce the next meeting's topic and the date as soon as possible. Thank you so much for all the faculty and the participants for the coming this webinar. Thank you so much.
Thanks a lot.
Yeah,
Goodbye.
thank you so much. Bye.
Goodbye, all the participants. Thanks a lot.